Hello everyone, I'm Pierre, an elbow surgeon based in Paris, and today I will discuss arthroscopic and open arthrolysis and the management of elbow stiffness. You know that post-traumatic stiffness occurs in nearly 12% of cases and reflects a disruption of the elbow's mechanical balance. The elbow should be considered as an elbow machine, a multi-level system regulating motion, and disturbance at any level may result in a restricting range of motion. In first, the central nervous system functions as a regulatory switch within the stiffness cascade. It assesses functional requirements and activates movement via peripheral neural pathway through articular nerve branches connecting to the capsuloligamentous plane. It contributes to release of substance P. Substance P is a key biological mediator in the development of capsular and muscular contracture. And in the next level, the flexor and extensor muscles could generate elbow motion through contraction. Post-traumatic and post-surgical contracture mechanically reduce extension and or flexion. You know it. However, the limitation is not purely mechanical. Joint injury induces arthrogenic muscle inhibition, altering neuromuscular recruitment and promoting maladaptive co-contraction. And at the next level, the final level, in fact, we find this capsule and the ligament, synovial fluid, and cartilage. The initial trauma led to inflammation and increased release of substance P, triggering an inflammatory and fibroproliferative cascade. This leads to capsular retraction, myofibroblast proliferation, excessive disorganized collagen deposition, and sometimes heterotopic ossification. The result is decreased joint compliance and a progressive reduction in range of motion. This is the post-traumatic stiffness. But clinically, when can we truly speak of elbow stiffness? To define elbow stiffness, we must first know how to measure joint motion. Personally, I systematically assess the flexion extension arc from maximal extension, defined at 0 degrees, to full flexion, which can reach 150 degrees. When reporting motion, I always state 0 degrees first. It represents the theoretical starting point common to all patients. Then I document the maximal extension achieved, followed by maximal flexion. In a normal elbow, this will be recorded as 0, 0, and 150 degrees, meaning no extension deficit and full flexion. Since the 80s, following Murray's article about elbow biomechanics, it has been accepted that activities of daily living can be performed within a range of motion from 30 degrees to 130 degrees, resulting in an arc of flexion extension under 100 degrees. But I think that this absolute 100 degrees criterion that Murray was pertinent in the 80s, but now it's outdated. The surgical indication does not rely solely on the degree of residual motion. Murray proposed an anatomical classification of elbow stiffness into 3 categories: extrinsic, intrinsic, and mixed. Extrinsic form correspond to cause located outside the joint: capsular contracture, ligamentous fibrosis, muscular or tendinous contracture, neuropathy, heterotopic ossification, and more. Intrinsic forms include intra-articular causes: adhesion, incongruity, post-traumatic deformities, cartilage lesion, osteophyte, or loose body, for example. But in reality, elbow stiffness is a complex and often multifactorial condition. In the vast majority of cases, it represents as a mixed form. And this classification, in fact, is useful to structure clinical reasoning, but it does not by itself guide the surgical strategy. What truly matters is identifying the predominant mechanism in the individual patient and tailoring the procedure accordingly. That's why other classifications have been proposed, notably by eliminating the mixed category and adding, for example, capsular and neurologic disorders. But more recently, a new classification was proposed in collaboration with Dr. Driscoll, the STIF, for stiffness, type, and influencing factor system. This classification outlines major type of elbow stiffness. Among this type of stiffness, heterotopic ossification, nonunion, and chronic subluxation are classic indication for open arthrolysis, obvious. But in contrast, arthritis and particularly soft tissue contracture may also be an indication for arthroscopic arthrolysis. However, when attempting to compare arthroscopic arthrolysis with the open technique, the literature remains limited. It was not until 1985 that the first series of elbow arthrolysis was published by Urbaniak in GBGSR. So the literature truly began to expand in the early 19th with a broader dissemination within the arthroscopic community through the work of Jones and Savoy, Nowicki, and O'Driscoll, Bird, and others. And finally, between 1998 and 2019, the outcome of only 607 patients who underwent arthroscopic elbow arthrolysis were reported across only 8 studies. Over this same period, more than 20 studies on open arthrolysis were published, including approximately 1,000 operated patients. But what should ultimately be remembered is that elbow arthrolysis achieves approximately a 90% success rate, whether performed through an open or an arthroscopic approach, with a mean improvement of more than 26 points in the MEPS score, whether the technique. However, there are differences between arthroscopic and open arthrolysis. The complication rate for arthroscopic arthrolysis is reported to be under 2%, compared with more than 6% for the open technique. Regardless of the approach, ulnar nerve neurosis and the need for a second arthrolysis were the two main reasons for revision surgery. The second major difference concerns the gain in flexion extension arc, approximately 40 degrees after arthroscopic arthrolysis versus more than 70 degrees after open procedures. Open surgery are generally performed for more severe stiffness with a preoperative arc of around 40 degrees, whereas arthroscopic is typically carried out in less stiff elbow with about 70 degrees of preoperative motion. And in more, the meta-analysis from Egendal's team showed that open arthrolysis combined with an external fixator was used in the most severe cases and resulted in a greater motion gains compared with open arthrolysis alone. You can also therefore understand that depending on the chosen technique, there is a specific relationship between range of motion gain and the risk of complications. And we typically observe a substantial gain in motion around 30 degrees with arthroscopic, along with a low complication rate. Open arthrolysis provides greater motion gain in patients who are more severely stiff preoperatively, but at the cost of a significant higher complication rate. In the most severe cases, the largest improvement in range of motion have been reported with open arthrolysis combined with an external fixator. However, this approach is associated with higher complication rates. However, this approach with external fixator is associated with higher complication rate. And finally, for this type of post-traumatic stiffness, the conclusion of the largest series and meta-analyses are consistent. After failure of a good conservative treatment of 6 months, it's preferable to begin with the least invasive surgical option and escalate in invasiveness only if necessary. However, beyond preoperative range of motion and the type of stiffness, other factors must influence the choice of arthrolysis technique. This is reflected in the STIFF classification, which recommends considering 5 key factors. One of the most debated is ulnar neuropathy, as it's one of the main causes of revision surgery, especially after arthroscopic procedure. So the presence of preoperative ulnar neuropathy is not contraindication to an arthroscopic approach. It's debated in literature, but it's also my opinion. In a series of 563 cases on delayed onset ulnar neuritis after release of elbow contracture, Sean O'Driscoll showed that its incidence and severity can be reduced by performing a limited open ulnar nerve decompression or transposition. And Miller and colleagues showed that a prophylactic release may be recommended in elbow with less than 100 degrees of preoperative flexion. And based on all these elements, you can determine whether you are dealing with a simple stiffness for which arthroscopic arthrolysis will be straightforward and effective, or a complex stiffness, in which arthrolysis will be technically demanding and or not recommended. In complex cases, the two most debated factors remain preoperative range of motion and ulnar neuropathy. These are not contraindications to arthroscopy, I told you, but rather key elements that should draw particular attention and be carefully considered when choosing the surgical technique, as well as any associated procedure that may be required. And in a modern approach, I think you should not focus solely on purely technical aspects. It's absolutely essential to consider the patient's background and goals as well. This involves analyzing the patient's overall characteristics, their history of present illness, and any associated upper limb or systemic lesion that may affect limb function or the patient's overall autonomy. It's of course essential to assess both hand and shoulder function as well. Thank you for your attention.